Welcome to another episode of Rehab Now, brought to you by the Rehabilitation Institute of the Caribbean in association with Winchester MRI, Immune Active Denk, and Almighty Studios. Today I have with me consultant physiatrist and rehabilitation medical doctor, Dr. Paula Dawson. What's up, doc?
Nothing much. Alicia, how are you?
I am well.
Hi, listeners.
Hi, listeners. How are you doing? Wish me a say hi, listeners, and us steering a space. All right. Remember, you can check out our social media pages on Instagram. It's Rehab Institute Caribbean, Dr. Paula Dawson, Alicia Taylor Music. And for Facebook, it's Rehabilitation Institute of the Caribbean, and our website, rehabcaribbean.com. And, of course, our YouTube page.
YouTube.
Also, Rehab Caribbean.
That's right.
Now,
You
today...
missed the previous,
yeah, man.
episodes.
If you missed them, you just go and check them out on YouTube. Free tube, you know what I'm saying? So today we're going to be talking about spinal cord injury rehabilitation.
Yes.
Yeah, man. Take me through that spinal cord thing, doc.
Right. So we're going to start from the top. Let's start from the top, Alicia.
Okay.
And so the spinal cord starts at the base of the brain and it continues down. And you can have different types. There are two main types of spinal cord injury: a complete lesion or an incomplete lesion. Meaning a complete lesion is where no nerve signal is going past the injury of the lesion. And so, for example, if you have an injury in the cervical spine, it's called a cervical spinal cord injury. If it's in the thoracic spine, it's called a thoracic spinal cord injury. And so, spinal cord injury can be complete or incomplete. What is incomplete? Incomplete is, well, let's do complete. Complete is where, say you have an injury at C5, and you can only do what the C5 muscle can do, which is 5-6. 5-6. Pick up sticks.
Got it.
5-6. Pick up sticks. And so
7, 8,
everything below that is zero power. Now you can have incomplete spinal cord lesion where you have injury at that level, but you still retain some function going down the spinal cord, right? And so we separate them. You can have quadriplegia, which means all four limbs are affected, or you can have tetraplegia. No, sorry, quadriplegia, tetraplegia, sometimes they use it together, or you can have diplegia, which is both legs. Excuse me.
Okay.
Yeah, man.
And that's paralysis.
And paralysis, yes.
Oh, okay.
And so the interesting thing about spinal cord is, now, depending on the level of the injury, that will determine how much function you have. And so I usually teach my students high spinal cord, let's take the spinal cord level injuries. Now, between C3, 4, 5, keep the diaphragm alive. So between C3, C4, and C5, those are the nerves that will help breathing. If you have an injury, in the spinal cord at 5 or above, you're going to need a ventilator.
Are you serious?
Yes, you're going to need a ventilator to breathe. So spinal cord injury is an injury to the spinal cord, so you lose motor function, sensory function.
And that's closer to the lower part?
It's closer in the neck.
Closer to the neck
It's
part?
in the neck. So it's a high spinal cord injury.
Wow.
And so that affects your upper limb and your lower limb, your bowel and bladder. Now, going further down the spinal cord, if you have, for example, C6, you lose the function of extending the wrist. C7, so spinal cord, they are able to bend the elbow, extend the wrist, but they're not able to straighten the elbow because that's C7.
Yeah, lay them straight, 7, 8.
Very good. And then C8 is dexterity, the ability to use the fingers to write, to touch, to hold a pen, to hold a fork, to comb your hair, that kind of stuff. And so that's cervical. So any spinal cord injury that involves the cervical spine is called quadriplegia, all four limbs, right? So because the track going up to the brain and going from the limbs to the brain and from the brain to the limbs is affected. So essentially, when you look at the spinal cord, you just have like channels.
Okay.
Channels of information going up. So if I pinch you, the sensory will go up to the brain and say, I pinched you. And it will tell you exactly where the temperature change or balance, etc. And then you have channels going down from the brain that will tell you, move your arm. Right? Will tell you to move your arm. And so the control. So you have information going up and down. So when you have a spinal cord injury, you cut that. You really cut that. And the question is, what causes a spinal cord injury?
I was just going to ask.
The main cause of spinal cord injury is traumatic. And so there's bimodal, meaning age-related. So the younger people will have motor vehicle accident, traumatic.
Yeah.
And then when you get to older folks, it's non-traumatic. And what do I mean by that? So as you grow older, the canal, because of spine arthritis and
Jesus.
spondylosis.
Arthritis in your spine?
Yes, you can have arthritis in the spine. And so because of narrowing in the spinal column, where the spinal cord is in the central canal, you get narrowing to the point where you can actually compress the cord. And then you get infarct to the cord, and then you lose function in the cord. And so, you have traumatic in the young people, and then you have atraumatic. Now, there are other type of atraumatic or non-traumatic spinal cord injury. A tumor can cause it. Infection can cause it. You can have inflammation, something called transverse myelitis, right? You can have tuberculosis, Pott's disease in the spine, and infection.
Right, because I wanted to ask, what about children who are born with certain, defects? I don't know.
All right, so I like that. There's something called spina bifida. That's what you meant, right?
Yes.
Yeah, spina bifida. So, all right, so when you are thinking of getting pregnant, you should really be taking folic acid, folate. Because folic acid will prevent you from having children with what we call spina bifida. Spina bifida is where the posterior, the back of the spinal column doesn't seal in organogenesis. What do I mean by that? During development of the fetus, where everything is kind of metamorphosizing and forming. Literally, when our fetus is developing, it looks flat to like a pancake. And then it just closes, and then you have the limb buds come out for the arms, and the limb buds come out for the leg. And then they close at the back. That's a neural tube. And then at the back, if you're deficient in folic acid, or for whatever reason you have arrest or interruption of that closure, you get spina bifida. What is spina bifida? Where you have a defect in the back of your spinal column, where you can have there's just a space and nothing happens. Or you can have a space and the meninges, which are the membrane around the spinal cord, or out pockets. Meningitis.
I wanted to ask, what does that have to do with meningitis?
So meninges is just the membrane, almost like a plastic membrane over the brain and over the spinal cord. It's a protective membrane.
Yeah, and when it's infected, you get meningitis.
It can also be inflammatory meningitis or infective meningitis. So children, you talk about infective meningitis, whether it's by viral or bacterial or fungal. It's a different cause of meningitis. But we're talking about where the meninges kind of out pockets. And so that's another type of spina bifida. But the one that will cause effect to the cord is where the spinal cord actually comes out. And so kids will be born with the spinal cord on the outside of their body. It's usually quick surgery that they do it, spina bifida, just when you're days old or so. They'll have to put back the neural content back inside, and the neurosurgeons will try and seal in. Many times those children will have weakness below that level because the nerves will be damaged.
Oh my.
All right. And so, getting back to the spinal cord, so you have different causes, and most common cause is trauma, fall, motor vehicle accident, diving, back in the day.
Diving?
Back in the day before...
You're not divers?
Yeah. I suppose now it might be gunshot wound, because gunshot wound is a missile going through the spinal cord.
Yeah, man, I know the gunshot definitely would...
shatter the cord and the bone, etc. And you can have stab wound. We've had stab wounds, ice pick or whatever, sadly so, knife through the spinal cord. Diving, where you dive and you're not realizing that the water is shallow, and you hit your head and you hyperextend and you break your neck.
How fragile is a spinal cord?
The spinal cord is very fragile. That's why it is in the vertebral column, and that's supposed to protect it. But if you breach the vertebral column, for example, you break it, your flexion extension injury or fracture of the bone for whatever reason, you can get a traumatic spinal cord injury.
But how strong is the vertebra?
Very strong. It's bone.
Bone.
It's very, very strong.
So you really have to go through some stuff.
It's like the skull. It's like your head is very...
Okay, you have to protect your brain.
You have to protect the brain, exactly. So these are some of the spinal cord injury that you can have. But you have different types. You have spinal cord injury that is only one side of the cord because of blood issue.
What?
Yeah, brown Sicard, where you can have like a stab wound on one side or injury just to one side. It can just be a central, just the middle of the cord, central canal, central cord syndrome, right, because of compression, or it can be down at the bottom of the cord. You have something called cauda equina or conus medullaris. These are different aspects of spinal cord injury. But let's get to the big spinal cord injury one. Either both hands, both legs, quadriplegia or tetraplegia, or waist down.
Yeah, I know about the waist down.
So the most common area for you to get a neck injury is flexion extension C6, C7. Because if you're driving fast and you hit a wall or something like that, you flex your neck, where you have most of the motion, that's where you're going to have the spinal cord injury. In the lower body, it's at just where the thoracic spine ends, because the rib cage will protect the thoracic spinal cord.
Yeah.
And so if you have, before we got across the chest seat belt, where you just had waist seat belt, you used to have a lot more paraplegia injury from motor vehicle accident, because you'd hit a wall or get a head-on collision and the body's going forward. But now we have the seat belt holding us back, so you don't get as much paraplegia injury.
Thank God for seatbelts.
Yeah, man. So spinal cord injury, it can either be complete, where you feel nothing below the lesion, zero movement, zero sensation. You can't control your bowel, you can't control your bladder, you cannot feel around the anus, right? So that's another way to determine if it's complete, whether you have anal sensation or deep anal pressure. That is how you determine if it's complete or not.
But you're able to walk?
No, nothing below the level of the injury. Incomplete now is where you have some feel. You still have the weakness, but you have some feeling in. You have perianal sensation. You can feel, or you can feel pressure. Yeah, spinal cord injury. So when we come back, I want to talk about the functional levels with spinal cord injury and then rehab of the spinal cord injury patients.
All right, so stay with us.
Yes.
And we're back with rehab now. If you're just joining us, we're talking about spinal cord injury rehabilitation.
Yes.
All right, Dr. Dawson, take us away. But we've been talking about the spinal cord rehabilitation. But I really want to know, is there any way that people can recover from this injury?
So that's a good question. The spinal cord, unlike the brain, recovery is very slim.
Oh God.
Very, very slim.
That's bad.
Yeah.
I mean,
It's
it's
very
hopeful.
slim.
I was so hopeful.
Yeah. The thing is, you see, because the spinal cord is so organized, similar to the brain, it's a organized fashion of how the fibers are laid down, running up and down the cord. And so when you injure that, even if the nerves can grow back, they wouldn't be able to grow back and find the nerve above or below, right? I mean, they have high-end research. They're trying to use neurofibrils. They're trying to use different things to inject growth hormone, to inject around the spinal cord to help.
So even if it's like a minor injury to the spinal cord, you're telling me that there's no recovery for that?
You know why I like that question? Because I jumped to the big spinal cord injury. Okay. So you have something called myelomalacia. Myelomalacia, which is like compression of the cord. And so with the myelomalacia, you'll get changes in the color in the cord. So the cord gets a little white. And those areas will be affected, where those areas control will be affected. And so, but again, spinal cord, once you have injury to the spinal cord, it's very slim that it will recover. Very slim. However, so what we need to do then, so when a patient gets a spinal cord injury in the acute setting, now I have had a patient who, when they came in, had zero power below the level of the lesion, but the patient is walking now. Why?
Okay,
She's walking now. Why? Because that patient at the time of diagnosis was an incomplete lesion. Why? Because even though they had paralysis of all four limbs, when I did the perianal sensation and pressure, they could feel it. And so where the sacral segment, which is the perianal, it runs very close to the motor track in the spinal cord. So it kind of tells me the spinal cord was in, here I'm going to use another word, in shock.
Okay.
So the spinal cord is just in shock. So just after an injury, the spinal cord kind of shuts down, and then you give it a time to restart again. Usually within 24 to 48 hours, you're in spinal cord shock. But when you do the examination, if you have deep anal pressure or reflex that we call bulbocavernosus reflex, you can indicate that you can get some recovery.
So how long after the injury was your patient able to walk?
I think it was 6 months.
Oh, not bad.
But yeah, man, after I think it was 6 weeks in hospital, the patient was able to move all limbs again.
Okay.
Right. But of course, because of the spinal cord injury, with the brain, similar to brain injury, you get spasticity. So there's some stiffness, there's some, the gait is not as smooth as we'd like it, but the wonderful thing is the patient is walking. Now, the thing with spinal cord injuries, what level injury will recover to do what?
All right, good. Thank you. Because I have another...
Tell me the question.
You always talk about rehabilitation and you say what physiotherapists do or what the persons at the Rehab Institute of the Caribbean do is they bring you to a place where you are able to function within the limitations
of your illness.
Yeah,
Very
illness.
good. Very good.
So I'm wondering if with the spinal cord injury, if that is the case,
That is the case. And so you want to maximize their function within the limitation of their disease. For example, someone is able to... All right, so any level spinal cord above C7, they cannot live independent.
Above C7?
Above C7. Cannot. Because with C7, you need to be able to extend your elbow. And that is how you can transfer from a chair to the toilet or from a chair. C7 spinal cord injury patients can drive a modified van where all the levers are around the hands. The steering wheel, the gas pedal, the brake pedal. We have people in Jamaica with spinal cord injury and they can't move their legs and they're driving.
Oh.
You get a rig in America, you buy the cars made from the
them.
manufacturers.
I've seen them and I say, wait, I have spinal cord injury and you can drive.
Right, but some of the guys at Mona Rehab, and we have some ingenious people in Jamaica, they actually do welding and connect the lever through, like the brake pedal and the gas pedal to levers around the steering wheel so you can use your hand.
And not your foot to drive.
Your foot to drive. And you have your wheelchair on the right side, you pull it over, you put it outside, you take off the handle, you lock the wheelchair, you transfer. So you have to be able to do that. Raise your bottom. So,
and the C7, they can raise themselves,
right.
but them can...
But they can't.
They don't have
so
any
C7,
function.
They don't have this. So you can't flex your fingers. Right? And so C7 is the level that you can become independent. So our goal for patients, for example, 3, 4, 5, the rehab goal will be to teach the patient how to teach their caregivers how to take care of them. They may need a ventilator, believe it or not. C5 injury, C5 might be able to do a little elbow extension. Elbow flexion, sorry. So you can give them specialized plates with specialized forks. And so they might be able to help to just bring the food to their mouth. And so you can have something called a balanced forearm orthosis, where it's a orthosis that keeps the elbow balanced at maybe about horizontal level, and they're able to flex because all they can do is flexion.
This probably don't have anything to do with spinal cord injury, but that nursery rhyme thing that they teach us in school, that's really about the spinal cord. That's 1, 2, buckle my shoe.
Right. So I'm glad you brought that up. It is the function of each level
of the spinal cord.
Of the spinal cord. So at C4 level, the C4 nerves come out. And the C4 nerves can make you do shoulder abduction. C5 level in the spinal cord will go to the C5 muscles, elbow flexion. C6 level in the spinal cord will go to the wrist, give you wrist extension. And then C7 level in the spinal cord still will go to your triceps to allow you to push up. And that push-up is what you need to go from side to side. Now, just below C7, you have C8 nerves, and that will go to your fingers. And that and the one below it, T1, will allow you to do dexterity to kind of...
So
like
you're from 1 to 8?
You have 7 vertebral bodies.
Oh, 7.
But 8 nerves. So there's an eighth nerve, but it doesn't have its own bone.
Got it.
So it kind of comes out between C7 and T1. And then you have the thoracic spine, and then you have the lumbar spine.
Lumbar, I know the lumbar.
You know, the lumbar spine. And so then we go to C8 and T1, those patients, they still can't walk. But then when you get into C8 and T1, they get finger movement, they can propel their own wheelchair. Right? And so the C7 patients cannot propel their own wheelchair. They can only do their own transfers because they can extend their elbow and push up from a chair and slide from the chair to the commode or to the toilet or to chair, bed to chair, you know.
They can't pick up things.
They're not able to pick up things. C8, T1 is when they can pick up things now. Now, there's a thing about a spinal cord rehabilitation which we take for granted is bowel and bladder management.
Okay.
When you get spinal cord injury, the bowel can become paralyzed. And so they can become, not paralyzed, but you lose continence. It's called a neurogenic bowel. So you're either incontinent, because, you know, when you want to use the bathroom and do a number 2, you feel it coming down, but a social conduct will allow you can't wait until you reach home.
Yeah,
right?
for you.
And so your external sphincter will contract. Similarly, when you want to pass urine, you feel the urine coming on, but your external sphincter, which is voluntary, will close off until it's appropriate to open. Well, in spinal cord injury, they do not have that voluntary control.
And so it just...
Right, and so, but the good thing in spinal cord injury, you can teach a spinal cord injury patient to be functionally continent. So we teach the bowel. So what we do is we kind of modify what they eat. We kind of give stool softeners, bulking agent, and then we use suppository and they disimpact. Believe it or not, they have to empty their bowl digitally. What does that mean? With their fingers. So you have to digital. Sometimes you can actually use, once the suppository goes in, you have the bowel will kind of through the autonomic nervous system, which is kind of independent of the peripheral nervous system. There's another nervous system which is independent of the spinal cord called the autonomic nervous system, and that is heart rate. Remember I mentioned it in the last episode. Heart rate, breathing, and bowel movement. So you can't control peristalsis. You ever see when your stomach growl? You can't stop your stomach from growling, right? And that's peristalsis. So there's that nervous system still works. The myenteric plexus, which is the local plexus. So if you stimulate it, you may have a reflex emptying of the bowel. So you can train the body to do that. So you're functionally continent. So you time bowel movement. Similarly, you time it. So you do it most of the time. They'll do it in the morning, they empty, and they can go on the road full continence.
Okay, and then
similarly with the bladder, they may have to do intermittent catheterization, where whether it's 3 times per day, they'll use a catheter, go in, empty the bladder, and they have full continence for the rest of the day. That's the beauty about spinal cord injury. They become independent again, right? And so C8. Now they can use their hands. Paraplegia patients, which is weakness below the level of the cervical spine, they can do most things because their hands are now perfectly normal. Yeah. They can cook, vocation is important. And so you want to train them what they're going to do. When I did my med school, at Harvard now, she's amazing. I can't remember her name, she'd kill me. But anyway, she teaches at Harvard now. She's spinal cord injury. And she is such a good doctor. She's a medical doctor, and she has a paraplegia.
Oh, she.
Yeah, man. We have a few doctors who are paraplegic, but of course you need to have the right setup and all of that. Yeah, man. Yeah. And then bowel and bladder management, mobility, wheelchair mobility, depending on the level of the injury. Now, when you get lower down the cord, you can use braces and all of that can help you, but we didn't even get to rehabilitation.
Because we're there far up on the algorithm, aren't we?
Yes.
Yeah.
But the important thing is rehab, unlike brain, you don't necessarily get full recovery back to normal or changes in the deficit. However, what rehab does is give you maximum function of what you're able to do, because you're going to get spasticity. We want to make sure you have full range of motion. There are braces that you may need to position your legs. Sometimes we'll put you at Rehab into the Caribbean, we have like a tilt table. We'll put you to stand, we strap you in and we tilt the table up to get you to stand up.
Oh,
right?
so you feel that.
Right, that gravity pull. But spinal cord injury is a beautiful area of rehabilitation where patients can be trained with a skilled rehabilitation team to be functional within the limitation of their injuries.
Good stuff. Thank you very much, Doc.
You're welcome.
And so that's all we have for spinal cord injury. I want to thank Power 106, our show producers, our engineer. And thank you to our listeners for today. Rehab Now is brought to you by the Rehabilitation Institute of the Caribbean, located at Suite 2A to C, Ligony Post Mall. Thank you, our sponsors, the Rehabilitation Institute of the Caribbean, providing medical care for function and performance, and you guys really do that. In association with Winchester MRI, Jamaica's first choice for MR imaging, Immune Active Denk, a combination of key active ingredients designed to boost the body's natural defense, and of course, Almighty Studios, a recording studio where we create worship music to praise, to worship, and to serve.
Hallelujah.
All right, that's all we have time for. Thank you so very much. Love you. Bye-bye.
Blessings.